Assalamu alaikum warahmatullahi wabarakatuh. The topic for discussion today is tubulointerstitial diseases of the kidney. These diseases primarily affect the renal tubules and interstitial components of renal parenchyma. They are characterized by tubular dysfunction with electrolyte abnormalities, moderate levels of proteinuria, and varying degrees of renal impairment. Often the urinary output may be relatively preserved for any given GFR, and indeed there may be polyuria and nocturia. Now, these are of two types tubulointerstitial diseases: acute interstitial nephritis and chronic interstitial nephritis. Acute interstitial nephritis is an immune-mediated disorder characterized by acute inflammation affecting the tubulointerstitium of the kidney. It is commonly drug-induced with proton pump inhibitors, fast becoming the most common cause, but can be caused by other toxins and can complicate a variety of systemic diseases and infections. The causes, this is the tabulated form of the causes of acute interstitial nephritis. Causes of acute interstitial nephritis are allergic, many drugs, but particularly penicillins, non-steroidal anti-inflammatory drugs, proton pump inhibitors, and nisalazine. Immune mechanism involved in autoimmune nephritis, uveitis, transplant rejection. Infections, acute bacterial pyelonephritis, leptospirosis, tuberculosis, hantavirus, and toxic causes involves myeloma light chains and mushrooms. Cortinarius can cause acute interstitial tubular nephritis. The clinical presentation is typically with the renal impairment, but in some patients with drug-induced acute interstitial nephritis, there is signs of generalized drug hypersensitivity reaction with fever, rash, and eosinophilia. Proteinuria is generally modest. PCR is less than 100 milligram per millimole, and tubular in type. Tubular in type means it is at times with granular casts. The urine may contain white blood cells and white cell casts, but is sterile on culture. Eosinophils are present in up to 70% of the patients. 70% of the patients, but this is a non-specific finding. Acute interstitial nephritis should always be considered in patients with non-oliguric acute kidney injury. There may be a rapid deterioration of renal function in some cases of drug-induced acute interstitial nephritis, causing the condition to be mistaken for rapidly progressive glomerulonephritis. Investigations include renal biopsy is usually required to confirm the diagnosis. This typically shows evidence of intense inflammation with infiltration of the tubules and interstitium by polymorphonuclear leukocytes and lymphocytes. Eosinophils may also be observed, especially in drug-induced acute interstitial nephritis. Often granulomas may be evident, especially in drug-induced acute interstitial nephritis or sarcoidosis. The degree of chronic inflammation in biopsy is a useful predictor of long-term renal function. Eosinophiluria may be present, but is not good discriminator for acute interstitial nephritis. Management of acute interstitial nephritis include withdrawal of the drug, which can cause acute interstitial nephritis, but high dose glucocorticoids, prednisolone 1 milligram per kg per day may accelerate recovery and prevent long-term scarring. Other specific causes should be treated if possible, such as sarcoidosis, tuberculosis, leptospirosis, and acute bacterial peritonitis, acute bacterial pyelonephritis, hantavirus infections. So, and in cases of autoimmune, steroids should be given. Chronic interstitial nephritis. First, I would like to show you these are the normal tubular histology. This is acute tubular necrosis in which this is the damage of the tubules, and there is interstitial edema and interstitial inflammatory cells, acute pyelonephritis. This is the nephrons with granulocytes and infiltration of the interstitium with the neuropolymorphs and leukocytes. This is acute interstitial nephritis with tubular inflammation and tubular infiltration and edema of the tubular damage. Chronic interstitial nephritis, which can lead to chronic renal failure. Chronic interstitial nephritis is characterized by renal dysfunction with fibrosis and infiltration of renal parenchyma by lymphocytes, plasma cells, and macrophages in association with tubular damage. The causes of chronic interstitial nephritis includes acute interstitial nephritis causes, plus, if they are persistent, plus glomerulonephritis. Varying degrees of interstitial inflammation occur in association with most type of inflammatory glomerulonephritis. Autoimmune immune or inflammatory glomerulonephritis, interstitial glomerulonephritis, such as sarcoidosis, Sjogren's syndrome, chronic transplant rejection, systemic lupus erythematosus, primary autoimmune disease. Then toxic causes include Aristolochia in herbal medicines, lead, and Balakan nephropathy, which also includes Aristolochia damage and includes the damage by mushrooms, fungal mycotoxin, and mushrooms such as Cortineris includes nephropathy. All drugs causing acute interstitial nephritis, tenofovir, lithium toxicity, analgesic nephropathy, cyclosporine, and tacrolimus. Other infections consequence of severe pyelonephritis develop chronic interstitial nephritis. Congenital and developmental causes, vesico-ureteric reflux associated with causation not clear. Vesico-ureteric reflux associated but causation is not clear. Renal dysplasias often associated with reflux, inherited, now well recognized, but the mechanism is unclear. Others, Wilson's disease, sickle cell nephropathy, medullary sponge kidney disease, nephrocalcinosis, Metabolic and systemic diseases include calcium phosphate crystallization after excessive phosphate administration, phosphate anemas in patients with chronic kidney disease, hypokalemia, and hyperoxaluria. The histopathological features of the chronic pathophysiology and histopathological features of chronic interstitial nephritis are the disease may follow on from acute interstitial nephritis that does not resolve or may be associated with ingestion of various toxins, drugs, or metabolic and chronic inflammatory disease. In many patients, chronic interstitial nephritis presents at late stage and no underlying cause can be identified. Genetic causes may underlie many of these cases. Toxins that have been associated with chronic interstitial nephritis include those contained within the plant, Aristolochia calamitous, birthwort. These are probably responsible for the severe nephrotoxicity that can be associated with treatment with herbal medicines in Asia and for Balkan nephropathy, which affects isolated rural communities in Bosnia, Bulgaria, Croatia, Romania, and Serbia, possibly through contaminated floor. The nephropathy is commonly linked with tumors of the collecting system, urothelial tumors, and is probably due to mutagenic effect of the plant toxin on the urothelial epithelium. Injection of mushrooms within the Cortinarius genus can cause a devastating and irreversible renal tubular toxicity. It is encountered occasionally in Scandinavia and Scotland. Clinical features of chronic interstitial nephritis are most patients with chronic interstitial nephritis presents in adult life with chronic kidney disease, hypertension, and small kidneys. Urinalysis abnormalities are non-specific. A minority of patients with salt-losing nephropathy characterized by hypotension, polyuria, and features of sodium and water depletion. People with chronic interstitial nephritis have an impairment of urine concentrating ability, so the specific gravity of the urine is low, and sodium conservation, which results in increased sodium excretion, and hyponatremia, which puts them at the risk of acute kidney injury due to salt and water depletion during an acute illness. Renal tubular acidosis may complicate chronic interstitial nephritis, but is seen most often in myeloma, sarcoidosis, cystinosis, amyloidosis, and Sjogren's syndrome. So these are the clinical features. The features of these associated diseases will also be present in these cases. Management is supportive in nature with correction of acidosis and correction of hyperkalemia, replacement of fluid and electrolytes as required, and renal replacement therapy if irreversible renal damage has occurred. If there is irreversible renal damage, the renal replacement therapy such as dialysis, hemodialysis, peritoneal dialysis, and renal transplant should be carried out. Now we go back again once to the interstitial, tubular interstitial nephritis topic. So, tubulointerstitial disease, these diseases primarily affect the renal tubules and interstitial components of the renal parenchyma. They are characterized by tubular dysfunction and damage with electrolyte abnormalities. There is hyponatremia, hypokalemia, hyperkalemia, and acidosis in these cases. Moderate levels of proteinuria and varying degrees of renal impairment, which is determined by GFR. Often the urinary output may be relatively preserved for any given GFR, and indeed there may be polyuria and nocturia. In acute interstitial nephritis is an immune-mediated disorder characterized by acute inflammation affecting the tubulointerstitium of the kidney, renal tubules, and the interstitium. It is commonly drug-induced with proton pump inhibitors, fast becoming the most common cause, but can be caused by other toxins and can complicate a variety of systemic diseases and infections. The common causes of acute interstitial nephritis are allergic, many drugs, but particularly penicillin and non-steroidal anti-inflammatory drugs, proton pump inhibitors, and mesalazine. Immune mechanism involved in autoimmune nephritis, such as SLE, transplant rejection, acute infections such as acute bacterial nephritis, leptospirosis, tuberculosis, and hantavirus. Hantavirus infections, such as, and recently coronavirus is also causing the same features. Toxic myeloma light chains and mushrooms such as Cortinarius infection, and this mushroom can cause acute tubular necrosis. The clinical presentation is typically with renal impairment, but in some patients with drug-induced acute interstitial nephritis, there may be signs of generalized drug hypersensitivity reaction with fever, rash, eosinophilia. Proteinuria is generally modest. PCR is less than 100 milligram mole, and tubular in type. Tubular in type means the urine may contain hyaline cast, or the urine may contain white blood cells and white cell cast, but is sterile on culture. Eosinophils are present in up to 70% of patients, but this is non-specific finding. Acute interstitial nephritis should always be considered in patients with non-oliguric AKI. Oliguric AKI, in which urine output progressively decreases and urine output less than 500 is called oliguric. Anuric, in which there is no urine output. There may be a rapid deterioration of renal function in some of the drug-induced acute interstitial nephritis, causing the condition to be mistaken by rapidly progressive glomerulonephritis. Renal biopsy is usually required to confirm the diagnosis. This typically shows evidence of intense inflammation with infiltration of the tubules and interstitium by polymorphonuclear leukocytes and lymphocytes. Eosinophils may be observed, especially in drug-induced acute interstitial nephritis. Often, granulomas may be evident, especially in drug-induced acute interstitial nephritis or sarcoidosis, such as and tuberculous granuloma can also be present in tuberculous glomerulonephritis, interstitial nephritis. The degree of chronic inflammation in biopsy is a useful predictor of long-term renal functions, that is chronic CKD, chronic renal disease. Eosinophiliuria may be present, but is not a good discriminator for an acute interstitial nephritis. The histological picture of normal is these are the renal tubules and the interstitium. In this figure B, acute tubular necrosis, there are scattered breaks in the tubular basement membrane, swelling and evacuation of tubular cells, and in places apoptosis and necrosis of tubular cells with shedding of cells into the lumen. This is the edema, interstitial edema, and this is the edema, shedding of the cells into the interstitium, into the tubule. This is acute pyelonephritis, acute bacterial pyelonephritis, a widespread inflammatory infiltrate that includes many neutrophils. Granulocyte casts are forming within some dilated tubules. This is the granulocyte casts are being formed within the tubules. Other tubules are scarcely visible because of the extent of the inflammatory damage. Other tubules are not visible in this case. Acute interstitial nephritis, allergic interstitial nephritis in this patient who received a non-steroidal anti-inflammatory drug, an extensive mononuclear cell infiltrate. This is mononuclear cell infiltrate in whole of the extensive mononuclear cell infiltrate involving the tubules seen. This inflammation does not involve the glomeruli, not shown. Sometimes neutrophils are prominent. Transplant rejection looks similar to this. Now, what is the management of acute interstitial nephritis? Acute interstitial nephritis is withdrawal of the offending drugs and high dose of glucocorticoids may accelerate recovery and prevent long-term scarring and damage to the kidney, such as prednisone 1 milligram per kg per day. Other specific causes should be treated if possible, such as sarcoidosis and tuberculosis, hantavirus, and toxins. Multiple myeloma should be treated in cases of mushroom toxins should be considered. Chronic interstitial nephritis is characterized by renal dysfunction with fibrosis and infiltration of renal parenchyma by lymphocytes, plasma cell, and macrophages in association with tubular damage. Chronic interstitial nephritis is characterized by renal dysfunction with fibrosis, infiltration of renal parenchyma by lymphocytes, plasma cell, macrophages in association with the tubular damage. The causes of chronic inflammatory, chronic interstitial nephritis are: number one, persistence of acute interstitial nephritis, and number two, glomerulonephritis. Varying degree of interstitial inflammation occur in association with most types of inflammatory glomerulonephritis. Immune or inflammatory, sarcoidosis, Sjogren syndrome, chronic transplant rejection, systemic lupus erythematosus, primary autoimmune, toxic, aristolochia in herbal medicines, lead, Balkan nephropathy, mushrooms, cortinarius, drugs, all drugs causing acute interstitial nephritis, tenofovir, lithium toxicity, analgesic nephropathy, cyclosporin, tacrolimus, infection, consequence of severe pyelonephritis, congenital and developmental causes of chronic interstitial nephritis include vesico-ureteric reflux associated but causation not clear, renal dysplasia often associated with vesico-ureteric reflux, inherited, now well recognized, but mechanism is unclear. Other, Wilson's disease, sickle cell nephropathy, medullary sponge kidney nephrocalcinosis, calcium phosphate crystallization after excessive phosphate administration in CKD patients for using phosphatinemas, hypokalemia, hyperoxaluria. These are the causes of chronic interstitial nephritis. Chronic interstitial nephritis causes include acute interstitial nephritis, glomerulonephritis, persistence of acute interstitial nephritis, glomerulonephritis, immune or inflammatory nephritis, toxic nephritis, drugs and infections, congenital and developmental, metabolic and systemic kidney diseases. Pathogenesis and of the chronic inflammatory nephritis is this disease may follow on from acute interstitial nephritis that does not resolve or may be associated with injection of various toxins, drugs, metabolic and chronic inflammatory diseases. In many patients, chronic inflammatory nephritis, chronic interstitial nephritis present at a late stage and no underlying cause can be identified. Genetic causes may underlie many of these cases. Toxins that have, such as vesico-ureteric reflux, renal dysplasia, vesico-ureteric reflux, and also the Wilson's disease, sickle cell nephropathy, medullary sponge kidney diseases, inherited with mechanism unclear, can cause chronic renal disease, and chronic inflammatory chronic inflammatory nephritis due to toxins that have been associated with CIN include those contained within the plant, Aristolochia clematitis, birthwort. These are probably responsible for the severe nephrotoxicity that can be associated with treatment with herbal medicines in Asia, and Balkan nephropathy, which affects isolated rural community in Bosnia, Bulgaria, Croatia, and Romania and Serbia, possibly through contaminated flow. So it is due to mycotoxin which infects the floor. The nephropathy is commonly linked with the tumor of the collecting system and is probably due to the mutagenic effect of the plant toxin on the urothelial epithelium. Ingestion are of mushrooms within the Cortinarius genus can cause devastating and irreversible renal tubular toxicity. It is encountered occasionally in Scandinavia and Scotland. The clinical features of chronic inflammatory chronic interstitial nephritis presents in adult life with CKD, chronic kidney disease, including hypertension and small kidneys. Urinalysis abnormalities are non-specific. A minority presents with salt-losing nephropathy. This results into hypokalemia, hypomagnesemia, and hyponatremia due to the salt loss, characterized by hypotension, polyuria, and features of sodium and water depletion. People with chronic interstitial nephritis have an impairment of urine concentrating ability, so the urine specific gravity is high and sodium conservation sodium so urine specific gravity is low and sodium conservation results in hyponatremia, which puts them at risk of acute kidney injury due to salt and water depletion during an acute illness. Renal tubular acidosis may complicate chronic interstitial nephritis in some patients, often in myeloma, multiple myeloma causing interstitial nephropathy. Sarcoidosis, cystinosis, amyloidosis, Sjogren's syndrome, all these renal diseases or systemic diseases can cause chronic interstitial nephritis. Management of the chronic inflammatory interstitial nephritis is supportive in nature, with correction of acidosis, hyperkalemia, replacement of fluid and electrolytes as required, and renal replacement therapy if irreversible renal damage has occurred, which includes hemodialysis, peritoneal dialysis, and renal transplantation. So these are the causes, management lines, and the management of the underlying disease also helps, such as multiple myeloma, sarcoidosis, cystinosis, amyloidosis, and Sjogren's syndrome. Papillary necrosis, the renal papillae lie within the hypertonic environment in the renal medulla at the end of the vasa recta. They are susceptible to ischemic damage because of this and can undergo necrosis when their vascular supply is impaired as a result of diabetes mellitus, sickle cell disease, long-term ingestion of NSAIDs, and association with pyelonephritis. The condition may occasionally occur in other diseases. There is an association with pyelonephritis, but it is difficult to determine whether this is a cause of papillary necrosis or a complication. The clinical presentation is variable. Some patients are asymptomatic and clinically silent, whereas others present with renal colic and renal impairment as necrosed papillae slough off and cause ureteric obstruction. Urinalysis may be normal, but more frequently hematuria and sterile pyuria are present. Significant proteinuria is unusual unless there is a renal feature, unless there is a renal failure. The imaging method of choice to make the diagnosis is CT urography or intravenous pyelography. Management is based on relieving obstruction where present and withdrawal of the offending drugs. Genetic renal diseases, the advent of modern genetic techniques such as next generation sequencing has allowed us to understand the breadth of inherited renal disease on a much deeper level than before. Inherited glomerular diseases are Alport's disease. A number of uncommon diseases may involve the glomerulus in childhood, but in the most important one affecting adults is Alport syndrome. Most cases arise from mutation or deletion of the COL4A5 gene on the X chromosome, which encodes type 4 collagen, resulting in inheritance of an X-linked recessive disorder. Mutation of COL4A3, COL4A4 genes are less common and cause autosomal recessive disease. The accumulation of abnormal collagen results in a progressive degeneration of the glomerular basement membrane. Affected patients progress from hematuria to end-stage renal disease in their late teens or 20s. Female carriers of COL4A5 significant mutations usually have hematuria, but less commonly develop significant renal disease. Some other basement membranes containing the same collagen isoforms are similarly involved, notably in the cochlea, so that Alport syndrome is correct associated with sensorineural deafness and ocular abnormalities. Alport syndrome, endothelial cells, glomerular basement membrane, glomerular capillaries, and urinary space, foot process of pseudopores. So, Alport's disease, a diagrammatic structure of the normal glomerular basement membrane. The normal glomerular basement contains mostly the tissue-specific alpha 3 and alpha 4 and alpha 5 chains of type 4 collagen. Alport syndrome, this network is disrupted and replaced by alpha 1 and alpha 2 chains. Although the glomerular basement membrane appears structurally normal in early life, In, in time, thinning appears and progressing to thickening, splitting and degeneration. Splitting and degeneration. Angiotensin converting enzyme inhibitors may show but not prevent the loss of kidney functions. Patients with Alport syndrome are good candidates for renal replacement therapy as they are young and usually otherwise healthy. They can develop an immune response to the normal collagen antigen present in glomerular basement membrane of the donor, and in a small minority, anti-glomerular basement membrane disease and destroy the allograft. The glomerular inherited tubulointerstitial diseases, it has become evident in the recent years that a significant number of the cases of CKD with low or absent proteinuria have genetic causes which may be inherited in an autosomal dominant recessive pattern. The histological pattern of injury is identical to the forms of chronic interstitial nephritis. This is a heterogeneous group of inherited disorders. Small cysts are somewhat evident and explaining the previous name of medullary cystic kidney disease, but tubulointerstitial nephritis is the predominant pattern of injury. Many of these conditions, especially those formerly known as nephrophysis, are associated with retinal dystrophies and brain and other abnormalities, and some may be associated with hyperuricemia or gout. Modern genetics have brought clarify to a disease spectrum comprising many different conditions with exact. Hereditary tubulointerstitial diseases are autosomal dominant and autosomal recessive. Autosomal dominant is genes are UMOD, MUC1, HNF1 beta, REN codes, MCKD, chronic kidney disease, medullary cystic kidney disease, type 2, juvenile hyperuricemic nephropathy. Clinical features are of gout, and in this case, progressive CKD without other manifestations, juvenile hyperuricemic nephropathy, cystic disease, solitary kidney, gout, maturity onset diabetes of young, abnormal LFTs, pancreatic atrophy, and hypomagnesemia, and in autosomal dominant REN gene defect, the juvenile hyperuricemic nephropathy characterized by gout, hyperkalemic, salt-losing nephropathy, autosomal recessive, HN, NH, NP, HP genes, 17 discovered so far, nephrophysis, part of the many syndromes, Bardet bleed syndrome, common cause of pediatric end-stage renal disease, occurs early than autosomal dominant interstitial nephritis. Extrarenal manifestations common, learning difficulty, eye and limb defects. So, once again, we go to the inherited tubulointerstitial diseases, pages 420 pages 404, 426, inherited tubulointerstitial diseases. It has become evident in recent years that a significant number of cases of CKD with low or absent proteinuria have genetic causes, which may be inherited in an autosomal dominant or recessive pattern. The histological pattern or injury is identical to or other forms of chronic interstitial nephritis. This is a heterogeneous group of inherited disorders. Small cysts are sometimes evident, explaining the previous name of medullary cystic kidney disease, but tubulointerstitial nephritis is the predominant pattern of injury. Many of these conditions, especially those formerly known as nephrophysis, are associated with retinal dystrophies and brain and other abnormalities, and some may be associated with hyperuricemia or gout, U-mode or HEFNA beta mutations. Modern genetics have brought clarity to a disease spectrum comprising many different conditions with inexact previous names. Hereditary tubulointerstitial kidney disease, autosomal dominant, is characterized by medullary cystic kidney disease, medullary cystic kidney disease with gene defect U mode and MUC1, HEFNA 1 beta, and then the medullary cystic kidney disease, type 2, juvenile hyperuricemic nephropathy, type 1, gout, characterized by gout, and progressive CKD without other manifestations, juvenile hyperuricemic nephropathy, cystic kidneys, solitary kidney, gout, and maturity onset diabetes of young and abnormal LFTs, pancreatic atrophy, hypomagnesemia, gout, hyperkalemia, salt-losing nephropathy, and autosomal recessive NPHP genes, nephritis, and part of the many syndromes in which Bardet-Biedl syndrome, common cause of pediatric and stage renal disease, occurs early than autosomal dominant interstitial nephritis. Extrarenal manifestation common, learning difficulty, eye and limb problems. Adult polycystic kidney disease, common clinical features are vague discomfort in loin or abdomen due to increasing mass of renal tissue, number 2, acute loin pain or renal colic due to hemorrhage into the cyst, hypertension, hematuria, urinary tract or cyst infection, renal failure. So the complications of this disease are baryaneurysm of cerebral vessels are associated features in about 5% of patients with polycystic kidney disease. investigation is by ultrasound and MRI. Management includes control of blood pressure and if end-stage renal, then there is management of end-stage renal disease by renal replacement therapies, including hemodialysis, renal transplant, or peritoneal dialysis. So this is all about interstitial nephritis, tubulointerstitial nephritis. लो जी बच्चों खत्म